about employing them. There's a couple of really key references there that James in particular and Pranav have helped us get onto the website, and those will tell you a lot of the answers for the way in which we're explaining things today. So the first of all is why and how did this come about? We've slightly lost focus on this a little bit with COVID, but the issue of the workforce crisis in the NHS in general, in mental health specifically, remains a significant issue and is going to continue to be something we struggle with. The NHS long-term plan and the interim people plan, which were published at the end of last year, emphasise the importance of us thinking differently about how we deliver healthcare, and in particularly focus on the development of the so-called new roles. If I think someone's got their speaker on, if you could just put your mics off, that would be helpful to reduce the amount of noise. Thank you very much. So three of the roles which I think are particularly pertinent to mental health are physician associates, advanced clinical practitioners and peer workers. And we're really going to focus today only on physician associates. We know that there will be a significant investment in mental health funding. That's what we have been promised. And the view of our president, Professor Wendy Byrne, is that this cannot simply go into what you might call traditional clinical roles, doctors and nurses. There simply aren't sufficient of them in the workforce to meet that need. And therefore, we really need to be thinking about how we can make use of new roles. I put COVID-19 in there because, as I'll be telling you, the physician associates that we have in our trust have been particularly valuable with COVID-19. And really, the issue of COVID simply emphasises even more the degree to which we have to think about physical and mental health together to upskill our teams, to manage the physical health of our patients, and to address the mortality gap that we know that there is. So next question really is, what is a physician associate? And I'm going to hand over at this point to Pranav. Are you there, Pranav?
Yes, can everyone hear me?
Yep, you're loud and clear, thanks.
Lovely. So yeah, we're talking about physician associates, so it's important to try and understand what a physician associate is, who they are, where they are, and what they can do. Hopefully, Twalia and Carolyn, who are a couple of our physician associates in Sheffield, will join this discussion and be able to put some meat on the bones. But essentially, what a physician associate is sort of described as they are healthcare professionals with a sort of a generalist medical education. They work alongside doctors providing medical care as a part of the MDT. They are currently dependent practitioners, so they need a dedicated medical supervisor, but they can work autonomously with appropriate support. At the minute, there isn't regulation, which is why they aren't able to work independently, but this is due to change fairly soon with the GMC agreeing to take on that mantle of regulation, but obviously there's a long way to go with that. So when we talk about physician associates, they have to come from somewhere, and essentially a physician associate course is a postgraduate course. It's roughly 2 years, and as you can see from this map, I feel a bit like a weatherman here, but as you can see from the map, there are courses across the country. So there are roughly 30 different institutions that are running these postgraduate physician associate courses everywhere in the country. And that's really important because generally what you find is that where the courses are being run is going to be sort of your main recruitment pool, as it were. A number of our physician associates have studied in Sheffield.
Thanks very much, Pranav. Have we got Carolyn and Twyla on the line? Are you able to talk to the next slide?
Hi, it's Carolyn. Tuala's having a little bit of problem getting on. She can't access her emails from the laptop that she was trying to join on, but hopefully she can join later. So in terms of who we come from a life science background. So for myself, I did my undergrad in neuroscience with pharmacology. A lot of people have healthcare background as well. So we do a 2-year full-time intensive postgraduate course, which include medical science and clinical reasoning, consisting of 50% theory and practice. This includes over I'd say 1,600 hours clinical placement. This is getting experience in both acute and community settings. So this starts really from an early point within the course. So from my experience at uni, I was in placement probably a week into the course. In terms of mental health exposure, we had a 3-week placement. I'm not quite sure if this varied for universities, but that's what I had. And in terms of what we can do, so we practice from a defined scope of practice within a wide variety of things. So we can take medical history, carry out physical examination, look at patient with undifferentiated diagnosis, see patient with long-term conditions. In terms of from a mental health point of view, so we can do mental state examination, carry out various different physical assessment. In terms of stuff that we can't currently do because of regulation and prescribing, right? So we can't prescribe, we can't request ionizing radiation. And in terms of mental health, we won't be able to do seclusion reviews at the moment. So that's sort of it from me.
Thank you very much, Carolyn. That's really helpful. I'm just going to go back for 1 minute and see if I can show you a film which I'd just like to share with the group, which I think will explain a little bit more about what physician associates actually do. Sorry, let me just get that up and running.
Services are set up to provide integrated care, both physical health and mental health. And there's been a big drive towards parity of esteem, so that mental health is treated on par with physical health. We all know that there is a huge workforce crisis within mental health services that has an impact on all of our teams. In our teams, we have psychologists, doctors, nurses, and occupational therapists. I think physician associate as a role adds to the strength of our teams so that we can meet our patients' needs much more effectively.
As a permanent member of the team, we often build relationships with specialists in local hospitals. That's really useful when we have, for instance, diabetic patients or COPD patients that we need more advice with. Being able to do this on the day saves a lot of time. You don't have to call out an SHO or a doctor to come in and carry out these tests, such as blood tests and ECGs, where they're able to give you the information straight away.
We don't rotate, so once we're based on our ward, we are obviously there to provide continuity of care. We can examine them, we can order investigations, complete the clinical skills, for example, to take bloods if that needs investigating, and we can come up with a treatment plan for the patient.
Sometimes we have a really anxious patient that's just wanting to have just 1 or 2 people that they know and are able to open up to. It is a passion to help make a difference in patient life.
I think there was a lot of initial sort of worry I myself was a BMA rep, and there was a general feeling amongst the BMA and doctors that these people are coming for our jobs. But actually, when I finally got to meet PA students and PAs themselves, that worry melted away. I was blown away, to be honest with you, about how passionate, how interested, how bright the students were. After a few weeks, a few months actually, everyone was a lot more comfortable, and actually this person is a valuable member of the team and there are things that they can offer.
This particular Wednesday morning I was there and we had a sick patient. It was very non-specific, nothing really that was shouting out to them saying that this is what's wrong with him, and it just took a little bit more delving in to kind of make that decision that this man does need to go to hospital, and it might not have happened as quickly as it did if, for example, I wasn't there.
I remember the junior doctors being very, very tied up with ECGs and taking out sutures and blood tests and things like that, and very rarely did I ever talk to a junior doctor about my mental health actually, so they weren't getting that opportunity to, you know, improve their psychiatry experience. The role of physician associate really fits in and benefits the team, it benefits the rest of the ward, it benefits the service users. I feel that the physician associates are really into what they're doing, they really want to know more, and I can't help but sit there and think I'd feel really, really safe in your care, and I think that's a really good feeling.
They bring in reliable clinical competence to attend patients' physical health. They free up my time to focus on mental health aspect of the patient's care. That in the long run will encourage more people to come into psychiatry because they know they can get the competent skills, whether it be mental health or whether it be physical health, because having to deal with two can be time consuming and probably we cannot have the time enough to attend for all of them. Physician associates are an integral part of the team.
So beforehand, before we had physician associates, it was quite difficult to get the treatments for our patients physically. So if a patient did come up with a physical health problem, we would have to contact other agencies like SHOs if we have a doctor on call, and that can be timely. So in a situation where patients have become unwell, the physician associates has made a massive difference in terms of time and quality as well.
I think if we didn't have a physician's associate, we would be contacting the on-call doctors a lot more.
To support physician associates in the organisation, we've set up an inceptorship programme for them run by our Department of Medical Education with some of the doctors here. We've chosen to have the physician associates on the inpatient wards because this is the place where we have the biggest workforce needs and also where their physical health skills can really add to the value to the needs of our patients.
Before we recruit to substantive posts, we hold a pre-recruitment open day and invite students from the universities in the region to come along and see what it would be like working with us as a physician associate in a mental health setting. We offer a full teaching plan for new physician associates, which includes half a day teaching with a higher trainee doctor to increase their knowledge and understanding of psychiatric matters. And we also provide them with help forming peer groups and any other staffing issues that they may encounter as a new physician associate.
I love physician associates because I see them as an incredible part of the team, and they tend to give me reassurance that there's somebody on the world who can deal with the physical health side of things. They do help to bridge that gap as part of the clinical team and ease off the pressure from some of us, which makes them an invaluable part of the team. And this is quite commendable and well appreciated by all the multidisciplinary team members.
Okay, let me just bring us back for a second. So Pranav, could I hand back over to you for a second to take the next slide? Is that all right?
Yeah, that's fine. So thinking about how you might want to integrate a physician associate into your team, and in terms of recruitment and what they need from you as much as what you need from them. The way that we've done it in Sheffield is we set up a 1-year inceptorship, because what we realised is that they are trained as generalists. They only have 3 weeks of sort of mental health training or psychiatry placements, and so using that sort of 1-year inceptorship alongside a teaching program to try and give them the information that they need to be as valuable a member of the MDT as possible with regards to mental health. From a physical health point of view, they're obviously very skilled. Following that 1-year inceptorship, the subsequent years are in as a band 7. They do need professional indemnity insurance, and I believe, is it the MPS who provide that, and they have a portfolio that is set up by the Royal College of Physicians. It's called the Faculty of Physician Associates, and within that they need to achieve sort of 50 hours of CPD per year. The way we achieve that is by setting up a weekly teaching program, which is roughly 3 hours a week, which myself and other higher trainees get involved in the teaching, but also encouraging the PAs to go and find their own teaching programs or their own teaching, which would sort of cover their more general training as opposed to potentially the mental health training. There are work-based placed assessments, and you can see a list of them there. It's not too dissimilar to a junior doctor's sort of checklist. And one thing that is quite unique about physician associates is that they are required to take their exam every 6 years, their recertification exam every 6 years. So it is important within those CPD hours that we encourage the PAs to go out and do their own learning, and look for their own courses, their own conferences that will keep them up to date with a lot of the physical health stuff, which will allow them to be able to pass the recertification exam when that comes along. So there's one thing working out what to do when you have the physician associates. It's another thing being able to recruit them in the first place, and specifically recruiting them to mental health. And we have been very fortunate in that most of the interviews that we've held have been very competitive, and we've had some really good candidates and recruits. And the way that we've looked to do that is by really encouraging students to come to our services and to integrate them that way. When they come, they now see physician associates on the wards, so they're able to sort of ask questions and see what a physician associate does in mental health. We ran open days for the local universities, so there are 2 universities local to us that we ran open days for, where we were able to give presentations, sort of workshop things on different tables, have our current PAs there as well to provide sort of feedback and support. But it's also important to get other staff on board. As you saw in the video, that there is inevitably concern when there is something new, and this sort of idea that physician associates are stealing our jobs and things like that. It's simply not true, but that reassurance is sometimes just as important to deliver to staff, so that they understand what physician associates are, and how they would potentially fit into different MDTs, and use your trainees. I think that's a big thing that we do. It's a really good opportunity for higher trainees to use their special interest time to improve their education, competencies, their leadership competencies, management competencies. And yeah, as someone who is currently doing that, it's been a really, really good opportunity for me.
Do you want to take this one as well, Pranav?
Oh, yeah, absolutely. So how, again, how do we ensure that physician associates receive the right information and the right education so that they are sort of skilled up to work within a mental health trust? So there are obviously going to be trust-led competencies, that often those sort of mandatory e-learning and classroom-based learning that we all have to do, but are extremely important when you've got somebody who's coming straight from university into a brand new trust. So things like record keeping, information governance, personal safety and de-escalation skills, ILS, mental capacity and mental health act training, safeguarding training, dementia and autism awareness. You know, these things that, you know, when we've done them every year can seem like a chore. When you're a new recruit, it's really important information to take on board. And then there's the medical education-led aspect, and this is sort of looking at really skilling up new recruits with regards what they'll need from a mental health and a psychiatry point of view. So looking at things like the psychiatric history, the mental state examination, starting to do work on formulation and psychological interventions, looking at differential diagnoses, but also other important things that we encourage, such as reflective practice, QI, and, you know, eventually getting involved with education themselves and maintaining a portfolio and work-based place assessments. The way we've done it in Sheffield is that for the first year, we provide sort of bespoke training or bespoke teaching for our PAs. As I said, sort of it's half a day release every week. In the second year, we encourage our PAs to then join some of the core trainee teaching, the sort of the MRC Psych specific teaching, and we pick out specific days that may be of most benefit for our PAs. Yeah.
Thanks very much, Pranav. Just two other things to say about that particular slide. One is that the study lead budget there that's down at the bottom of that slide, that's our decision. There's no national guidance on that, but I think it is important that they do have a study lead budget, particularly as time goes on, because in the longer term, these employees are not trainees. They will need to take responsibility for their own training, and they'll need a budget to do that, partly to maintain their relationship with the other physician associates, and partly, as we said before, because of the need for them to retain their generic competencies, such that if they did want to move into a completely different role, they would be able to become physician associates in acute medicine, surgery, obs and gynae, or whatever else. And of course, because of the requirement for them to retake their exams every 6 years. Is Michelle there? Michelle, would you like to just talk a little bit more about the Sheffield experience and our current state?
Yes,
Thanks.
That's absolutely fine. Hi, everyone. So in Sheffield Health and Social Care, I have been working in the trust for 2 years. When I first started working here, it was just the beginning of the PA journey for the trust. So we had just had our first open day and then went on to recruit shortly afterwards. We've had 3 recruitment rounds so far, trying to recruit 4 each time. And the last one, we managed to only recruit 3 new positions plus a position to fill a vacancy. Basically, the most helpful things I would suggest is that to have an open day involving the universities and then recruit afterwards, because you do tend to have the interest there and it's at the forefront of people's minds, so then they go ahead and apply. We have had quite a lot of interest each time when we have gone out to recruit. Unfortunately, the last time we only managed to recruit 3, but that was intentional and it wasn't because of the lack of interest. So at the moment in the trust, we currently have 8 qualified physician associates. We have an assistant physician associate starting on Monday and 2 further PAs that are due to start in mid-July. We tend to be as flexible as possible when it comes to start dates and recruitment, giving the assistant PAs opportunity to finish their course and plan a start date around what suits them best. We have had 2 resignations of PAs in the same position, but I did an exit interview for those and there was nothing to do with the placement itself, and also nothing really to do with Sheffield. It was more, the issues were more to do with commuting and going into GP areas. We tend to recruit the physician associates straight onto a band 7 from appointment. I don't know if that's something that is nationalised. I know that in the slides it mentioned band 6, but we do recruit band 7 with a band 4 position for the assistants until they qualify. As per the video, there was some scepticism from the trainees in the beginning, but we did involve the trainees. We have a trainee improvement forum, which we try and have twice a year, and we try to involve the trainees in that. So hopefully we could put their minds at ease when it came to the recruitment of the first set of PAs. As per the slide, Holly and Pranav take a lead in the teaching, and the medical education and staffing team are here to support the PAs. We manage them alongside the junior doctors from a HR and staffing perspective, organising their leave and payroll queries, etc., along with the medical staffing side of things, rather than expecting them to go through our usual HR route.
Thanks very much, Michelle. That's really helpful. I'll just clarify one issue that you mentioned, which people may be interested in, and that's the banding. So the national agreement, as Pranav mentioned earlier on, is for them to be employed at band 6 in their inceptorship year, their first year post-qualification, and then pending a successful outcome of that, to moved on to band 7. The reason we decided to employ all of ours on a band 7 is that our local teaching hospital were doing the same, acute teaching hospital, and we felt that we didn't want to be offering anything different from them. So as they were using band 7, we did the same. It may be that we change that in the future, but the national guidance is for band 6 initially. Okay, and finally, just to clarify the college position on this, just as in everything else, it's been a relatively fast-moving journey here, and in the college as well, there was a degree of scepticism initially. Professor Wendy Byrne has been an absolute champion for this. Recognising the value of this, particularly as going back to the beginning of my talk, in view of the additional funding coming into mental health and the workforce problems that we have. We see this as an enormous opportunity. She's set a target for 10% of physician associates in the country coming into mental health, which would be the equivalent of what we should be getting in consultant psychiatry time, for example. And Adrian has also given his full support for this. The College Council has also broadly supported this position, particularly because the college has been given a significant amount of funding to promote this from HEE, and that has enabled the project management work from James, who's running this session today, and the support that he's providing within the college. The pieces of work that we've done, we've made reference to the film, the toolkit, and the web page, which you'll find on the college web pages. We've now got a dedicated page which includes a lot of these resources. And James also manages a Twitter account, which has been very valuable in keeping contact with physician associates who are working in mental health, of whom we think there are around about 60 in the country now, and also physician associates, students who might be interested in working in mental health in the future, and how we can support them to try and match them up to potential employers. So I'm going to finish the presentation there. I'm very aware
So I think we've just lost Helen there for a little bit. We'll just give her a couple of minutes to get back online. But she was wrapping up the presentation.
And I'll pick up the questions as I go along. James,
sorry.
are you there?
Yeah, sorry, Helen, we lost you for about 30 seconds there.
All right, sorry about that.
It's fine. So yes, so thank you for the presentation. I just sent you an email with a couple of questions, but I can read them out to you if that's easier.
Thank you, that would be great.
Yep, just 1 second. So the first question is wondering if if physician associates can fulfill the roles of junior doctors from foundation year 1 to CT levels.
So I would say very clearly
Unknown
no.
Participant is now joining.
I don't think they can. I don't think they are the equivalent of doctors in many different ways. So first of all, their training, as we've already talked about, is a 2-year training following a graduate
Sorry, everybody, we've just lost Helen there for another minute or two. As soon as we get her back, we'll ask her to finish the answer. Sorry, Helen, we just lost you again there.
Yes, I saw that. Sorry. So I'll just repeat that. So are they the same as doctors? No, is the answer. I don't think they're going to be replacing doctors, either foundation doctors or CTs. However, they will have the opportunity to work alongside doctors. And my view, and I think the view of our trainees, is that they enhance our trainees' experience. So rather than our trainees getting involved in routine work that really doesn't progress their training, whether that's blood taking or looking into relatively minor physical complaints, I think our physician associates will develop those skills. The other thing that our consultants have enormously valued is the fact that physician associates don't rotate. They stay with the team and they stay they develop the relationships with the team, and they continue to work with that consultants. And that's something that our consultants have enormously valued. And from the time when we've started employing physician associates to now, we're now getting consultants begging us to give them a physician associate. I'll just take a couple of questions that I can see on the chat. There's There's something from Julie here. Would we be able to share job descriptions? Absolutely. They're already out there. They're in the toolkit, the HE toolkit that we've made referenced. And James has clarified that there.
Sorry, Helen, we've just got another question here, which I picked from the chat. Do you have any specific advice on how to find the balance between junior doctors on the ward and the physician associates? For example, juniors potentially avoiding any physical healthcare, but needing to maintain their own competencies in this.
So I haven't, I'll ask Pranav to comment on this in a minute, but this isn't something that I've detected to be a problem.
I think we might
physician associates. Our physician associates initially worked on the wards. Carolyn and Twala, maybe they would like to comment as well.
From my perspective as a junior doctor, I don't think that there's any shortage of work, sort of ward jobs for junior doctors and physician associates to be getting involved in. I think it's about what we want our junior doctors and physician associates to be doing whilst they are on placement with us. Do we want our F1s and F2s to be getting stuck in with physical health assessments, or do we want them to be using their 4-month rotations to improve their psychiatry skills and potentially coax them into a career in psychiatry, attract them, sorry, into a career in psychiatry, because they're actually taking mental state examinations, they are sitting in MDTs, they are getting involved in assessments, shadowing mental health act assessments, because they're having the opportunity to do that. So I certainly haven't experienced any shortage of work or any problems with regards to balance there.
From my experience on the ward, as Pranav said, there's no shortage of stuff to do, but we do work closely with the junior doctors. You'll find that some are more interested in some of the physical health stuff and will share that out. And if I've got any sort of concern or worry about a patient physical health, I can go to them and they'll still have input into that. So it's not like they're not getting involved in that area. Don't know if Tuala's got anything to add.
Hi, I think at first it was a bit of the case of I was doing most of the physical health stuff and the junior doctor was doing more of the mental health stuff, but then I had an interest in the mental health side. They went to be more like doing more things with the physical health side too. So now we just create a shared job list and then we pick what we'd like to do. So one side's not lumped with the other, if you know what I mean.
Great, thank you very much. We've got another question here, Helen. The clinical case to employ PAs is very strong, but how would you go about making the economic case for them?
Okay, so I think this is two parts to this question. The first is the one I've already emphasised. There is more money coming into mental health services, and we're going to struggle to find the people to employ. There won't be sufficient to make up that, and that's one argument for using a new type of workforce. This workforce will, in the long term, I think, be cheaper. They are employed on a band 6 and a band 7, as I've discussed earlier. They are banded according to Agenda for Change, and unlike a doctor, they won't go on to have the sort of trajectory of income that a doctor would accrue as they go through their development in the case. I think the other thing is to talk about the people working to the top of their grade. You know, the idea that if we've got expensive members of the team, they really shouldn't be doing jobs that other people can do routinely. That's not to say they shouldn't be able to. I mean, I hope I can still take a blood sample if required to, but actually I don't spend any of my time doing that. And I think that's right. That brings me to another point, actually, because people often say, physician associates, well, that's great, they can take blood, they can do ECGs, etc. But actually, they're too highly qualified for that to be their routine work. We ought to be having, you know, band 4 nursing associates or whatever, or phlebotomists or whatever else doing bloods on a routine basis. But clearly they need to be able to help, and they are situated in the wards and in the environments where this needs to happen quickly. So they're able to help out. But for me, the value of the physician associates over and above a phlebotomist or an ECG taker is that they recognise the need, they act on it in their own, you know, according to their own knowledge, and they then can make recommendations for treatment and make decisions about how to manage that further on. As we've already pointed out, they can't prescribe as yet. That's because they're not registered by the GMC, although that will happen in due time, in due course. But they are what is called prescription ready. In other words, they have had all the training of the top 100 drugs and medications that are prescribed. They know how to write a prescription. They know the legal requirements of writing a prescription. And indeed, in many other areas of the health economy, particularly primary care, they are actually writing out the prescriptions that they think are appropriate, and then those are being signed by their supervising doctors. We're not making as much use of that capability at the moment in mental health because there's less of a need to it, but that is something that we could think about doing in the future. I hope that answers your question, Peter. I don't know, you're welcome to come on and develop the question if you'd like to.
No, I think that covers it. Thank you.
Great. OK, we've got another question here about supervision. Where trusts are already using PAs, who acts as their line manager? Is this an operational manager or a doctor? OK, so we have chosen to link them very closely to our medical education department because our medical education department also has an HR responsibility. But their line manager is their consultant supervisor. So they are the person to whom they are accountable in that first instance, just as a doctor is. That should be a consultant, but that role can be delegated down to an appropriate SAS or associate specialist or GP if that's the model that the team are working with. But the guidelines do say that it should be a consultant or a general practitioner, unless there's an agreed a delegation of that. They require supervision on a regular basis, but it is not specified exactly how much supervision they should have or how that should occur. As Pranav's already indicated, when they come into clinical practice, they are pretty inexperienced. They've had relatively little clinical experience and they do need quite close supervision. But that is supervision not in the traditional medical model of an hour a week from a consultant, but very much from the whole team, from the nursing managers, from the other team members that they are working with. And indeed, we don't stipulate an hour's supervision per week. We have the usual requirement for 4 supervisions per year, which applies to any member of staff in the organisation. But of course, they will require much more initially. And as they become skilled in their area of work, they will be able to work under much less supervision and much more independently. Thank you very much. So another question, how do you deliver teaching for PA students during their placement, given that they have a 3-week placement in mental health?
OK, so we take students from the University of Sheffield and from Sheffield Hallam University. One is attached to a medical school, the other one isn't. They both come for a 3-week placement with us, and we give them the same sort of experience that we give our medical students, albeit curtailed because it's 3 weeks rather than 6 weeks, which is what our medical students get. The requirement from the universities is actually not very specific, so we developed our own standards for this. The national requirement is simply 90 hours in mental health, and I think that's very differently interpreted in different parts of the country. What we've said is that we want them to have approximately a week in an adult psychiatry setting, approximately a week in an older adults setting, and then they may get some other experience as well in their 3rd week. They are required to do particular assessments around certain diagnoses like depression, dementia and psychosis, but that's all that they're required to do. So yes, that's what we do. But I believe that's done very differently across the country.
Thank you, Helen. Another question, what is the long-term offer for physician associates in terms of development and career progression to ensure that this is a sustainable way to make up the workforce?
Yeah, it's a really good question, Charlie, and it's something that was discussed at the meeting we had at the college a few months ago before lockdown arrived. There's 2 different views on this. Some people think, well, how on earth are we going to keep these people in their roles as they develop experience? But I would say that they are employed under Agenda for Change regulations, and so they can progress through Agenda for Change depending on the nature of the work that they do. Some of the physicians if they were developed further. We haven't done that yet, but we're just looking into, because we now have a number of PAs, so we have a significant teaching commitment to the student PAs as well. We're looking into developing a part-time tutor, which would probably come out as Agenda for Change 8C.
Great, thank you, Helen. I've got one final question here. Why employ a PA rather than an ACP from an RMN background who are more experienced and can prescribe at band 7?
Yeah, this is a really meaty question, and I don't think I've got a straightforward answer to it, except to say that I'm backing both horses. We have a number of ACPs as well in the organisation. I've been part of the college working party developing competencies for ACPs in mental health, and we should certainly be supporting them as well. It's interesting training both groups, actually, because they are really rather complementary. So the physician associates come in well versed with a medical model of understanding, with significant medical skills. They think like doctors, and that's both an advantage and a disadvantage depending on your position. They come in with relatively little skills, and we need to skill them up in how to do more psychological medicine, because that's not their expertise at all. Our ACPs in this trust, they're all nurses, come in with vast amounts of clinical experience. They're enormously clinical experienced, but they don't think like doctors. And we are teaching them and training them and giving them the appropriate learning experiences to develop the skills that are familiar to doctors: differential diagnosis, physical examination, thinking about prescribing, etc. But they're coming to that later in their careers. My thought is that two groups should really be getting together, because I think they have the complementary skills that working together, they should be able to help one another. And indeed, we do have ACPs on a number of our acute wards at the moment. I wonder whether Chetwala and Carolyn would like to comment on that. I think you have some ACPs working on your wards, is that right?
Hi, and yeah, so I've got a ACP on our ward, and yeah, as Helen said, we come from more of a medical model thinking, more like a doctor, when they've got more mental health knowledge. So putting that together does complement each other. And I think working together is probably the way forward.
Thanks very much. There's just two other things that I wanted to talk about that we haven't quite covered yet, which I wondered might come up in questions. The first one is the issue of them being unregulated. This causes a degree of anxiety to people around this. What I would say is that the Royal College of Physicians, who's taken physician associates under their wing, under the Faculty of Physician Associates, have set up a number of things to assist with their employment, including appraisal, documentation, some of which we've shown you, but also they have a what's called the Managed Voluntary Register. So all the physician associates that we have are on this register, which requires them to fulfil the requirements, a little bit similar to that of an appraisal for a doctor, as discussed before. There's nothing to stop anybody going out and declaring themselves a physician associate and working, although as we've said before, they have to work under a doctor. But our strong advice, and certainly the advice of the college, would be not to employ a physician associate unless they were under the managed voluntary register that the college is maintaining. There's one other thing we made reference to earlier on that I just wanted to clarify. We've talked about the employment of physician associates at band 6 and or band 7, depending on your viewpoint. But Michelle also mentioned the fact that we were also taking on physician associate assistants, a slightly clumsy term, I acknowledge. The reason that we did this originally was because one of our physician associates whom we had employed had not yet got her exam results back, and then didn't manage to pass an element of the exam. So we felt that rather than postponing her employment with us for another period of months while she retook the exam, that it would actually be better to employ her as an assistant, and we redevised a job plan to manage that, and that's part of the toolkit as well. So she was employed as a band 4 for a few months until she passed her exam. This is not uncommon practice, and indeed in the recent COVID crisis there's been a move towards employing a lot more physician associates in this way, because for some of them their education has been curtailed by the COVID crisis, although that should be picking up again fairly soon. The other advantage that it gave to us, and I do think this is something worth emphasising, we set up our programme at the same time as our local large teaching hospital set up its programme, and our local primary care group also started pushing for physician associates in primary care with great enthusiasm. And we were concerned that we wouldn't attract physician associates into the trust, which is why we put so much effort into the hearts and minds element of trying to work with the universities, work with the students, encourage them to consider a career in mental health. But it's also a reason that we went early with our recruitment and picked them up and recruited them before they had qualified, because we knew that there was going to be a lot of competition. I don't think that's going to reduce. I mean, we've been lucky. We've had a lot of interested people apply for our jobs, and we've had no problem in recruitment. But I know in other areas that has been challenging. So that relationship with the universities, that engagement with the students at an early point, and that pragmatic approach to employing them, I think has won us a degree of respect from them.